Hi, everyone, and thank you for joining us today. My name is Stephanie Doback, and I'll be the moderator for today's webinar titled The Conundrum of Constipation Managing the Burden of Bowel Dysfunction for People Living with ALS. I'm excited to introduce our speakers, Dominique Koss and Brittany Hitson. Dominique was born and raised on the north side of Chicago. She received a Bachelor of Science in Nutrition and Dietetics from Dominican University and completed her dietetic internship at the University of Michigan Hospitals and Health Centers. She completed a Master of Public Health and a concentration in epidemiology at Loyola University Chicago. Dominique has a certificate in nutrition support and is currently working at Northwestern Memorial Hospital as an inpatient advanced clinical dietitian in the medical intensive care unit. In addition, she and Brittany are dietitians at the Lewis Insalia ALS Clinic at the Les Turner ALS Center at Northwestern Medicine, providing nutrition care and counseling for people living with ALS since 2016. Brittany is an Alabama native who moved to Chicago in 2018. She received her Bachelor's of Science in Nutrition Dietetics with a minor in business in 2016 from Auburn University. She then went on to obtain her Master's of Science in Clinical Nutrition from the University of Alabama at Birmingham in 2017, where she also completed her dietetic internship. In 2023, Brittany obtained a board certification as a specialist in gerontological nutrition from the Commission on Dietetic Registration. She is currently practicing as an advanced dietitian at Northwestern Memorial Hospital in downtown Chicago and splits her time providing support to both the medical surgical unit as well as the Lois and Salia Clinic at the Les Turner ALS Foundation. She has been a part of the ALS clinic team since 2020 and assists in coordinating inpatient ALS G-tube admissions. Lastly, we want to thank the ALS Association for providing the Quality of Care Program grant to support this presentation. And with that, I'll hand it over to Dominique and Brittany.
Thank you, Stephanie.
Thank you. Thank you
I'm-
for the.
yes.
Oh, go ahead.
I was going to say, I'm Brittany.
I'm Dominique.
So we'll go ahead and get
All
started.
right, here we go. All right, we have no disclosures. Our objectives are to discuss the effects of constipation and gastrointestinal dysmotility in people living with ALS, discuss dietary fiber in relation to ALS, and discuss practical implications to address constipation in PALS, including diet, enteral nutrition support, hydration, and pharmacological management. All right. People living with amyotrophic lateral sclerosis progress differently in the disease, with some losing ability to move, swallow, and breathe. Secondary symptoms include constipation leading to discomfort, which can reduce oral intakes and subsequently impact quality of life. The disease progression in ALS includes bowel dysmotility, and therefore the registered dietitian nutritionist is challenged with finding applicable interventions in this progressive disease. Okay, so the prevalence rate of constipation in the general population is 20%. However, the literature can range from 2 to 27% due to differences in study populations and definitions used, with the highest rate of constipation found in the elderly population. Specifically to PALS, Samara et al. Surveyed a cohort of 66 PALS regarding bowel, bladder, and sudomotor symptoms before and after diagnosis using questionnaires. These surveys were administered at the second multidisciplinary ALS clinic visit or later, and another survey administered at follow-up visits ranging from 3 to 6 months to determine changes in prevalence rates. Using the Rome-3 questionnaire, they found that 33% of PALS reported constipation prior to diagnosis, with 65% of PALS reporting constipation after diagnosis. Those PALS who completed a secondary survey at the 3 to 6 month clinic visit found a prevalence rate of constipation at 59%. According to the literature, constipation is one of the most frequently reported gastrointestinal side effects of ALS. As you can see, a prevalence rate of 59 to 65% after diagnosis is higher than the general population at a 20% prevalence rate. So what are some contributing factors? Diet composition. Brittany will touch on this later in this presentation, but in short, but into our oral intakes and diet composition can drastically change with the progression of disease. Some pals may need to make texture modifications to their foods and will intentionally select more calorically dense foods, which can reduce the total intake of dietary fiber. Dysphagia is a contributing factor to texture modifications and can lead to decreased total fluid intake and dehydration. In addition to limiting fluid intake, sialorrhea may contribute to dehydration, in addition to some medications causing constipation. PALS may intentionally limit fluid intake due to decreased mobility and need for assistance to and in the bathroom. In addition to decreased activity and limited mobility, PALS may have an inability to coordinate abdominal muscles and may have a subconscious hesitation to move their bowels. ALS is a neurodegenerative disorder with aspects of autonomic dysfunction. However, there is little known about the gastrointestinal changes in PALS before and after diagnosis. It has been suggested that ALS may affect motility and transit time through the gastrointestinal tract. Topher et al. Assessed gastric emptying using 13C octanoic acid breath test. This study found a delay in gastric emptying in 14 of 18 PALs. Furthermore, they measured total and segmental colonic transit time using radio-opaque markers. They found that 11 of 14 PALs showed a delay in colonic transit time when compared to healthy controls. Russo et al. Evaluated gastrointestinal motility of the small bowel by measuring mouth to colon transit time, MCTT, or gastric to colon transit time, GCTT, using the non-invasive hydrogen breath test technique. This study compared 7 healthy controls to 6 patients with probable or defined ALS. They found that MCTT was significantly prolonged compared to healthy controls. They also found that MCTT increased as the ALS-FRS-R score decreased, which may have suggested a change in small bowel involvement as the disease progressed. Similar to Rousseau, Schaff et al. Examined MCTT in 23 PALs compared to 19 healthy controls using the non-invasive hydrogen breath test technique. They found similar results to Rousseau, with MCTT in PALs significantly longer compared to healthy controls. Furthermore, they found MCTT increased as the ALS-FRS-R score decreased, suggesting once again a progression of small bowel involvement as disease severity worsens. So what may be the impact? Gastrointestinal dysmotility may contribute to bloating and generalized discomfort associated with eating. Impairments in gut function and delayed gastric emptying can also impact the release of gut hormones associated with appetite and can alter the perception of hunger and satiety. These feelings of early satiety may exacerbate generalized anorexia in this population.
So, with the research in mind that rates of constipation are elevated and that this may be causally related on some level to gastrointestinal dysmotility, we may typically need to lead our care with the assumption that a PALS might need specialized adjustment to the general dietary recommendations. So with that in mind, let's dive into the diet considerations you may need to take into account for PALS. I'd like to start the diet portion of our discussion with a quick review on dietary fiber, the types, where it can be found, and the intake recommendations for the healthy population. The 2005 Dietary Reference Intake for Healthy Individuals generally recommends between 25 and 38 grams of dietary fiber per day, dependent on the age and the sex of the individual, with about 28 grams per day recommended based on a 2,000 calorie per day diet. So soluble and insoluble fiber are both suggested to normalize and improve bowel function, and most plants contain both soluble and insoluble fiber in varying amounts and ratios. Soluble fiber works by attracting water and turning to gel during digestion, which can aid in slowing gastric emptying, inhibiting absorption of glucose, and decreasing both triglyceride and cholesterol levels. It also plays a role in short-chain fatty acid production in the large intestine. Soluble fiber can be found in oats, peas, beans, apples, citrus fruits, barley, and psyllium. Insoluble fiber adds bulk to the stool and can help food pass more quickly through the stomach and intestines, which may stimulate bowel function and increase fecal mass. Insoluble fiber is found in whole wheat flour, wheat bran, nuts, beans, and vegetables such as cauliflower, green beans, and potatoes. Because of all of these benefits on GI function, increasing fiber intake is a common clinical recommendation for the management of constipation. Now to delve into the current available research on the intake of fiber in relation to ALS specifically. Currently, there are limited studies that focus on the relationship between dietary fiber and ALS, but the literature that is available has largely focused on the relationship between dietary fiber intake and disease progression and survival times. So a few studies of note. In some more recent emerging research, the intake of fiber-rich foods has been found to be positively associated with ALS FRSR scores and slow disease progression in PALS. Specifically, you et al. Investigated the relationship between disease progression rate and survival time with the intake of different types of dietary fiber in 272 Korean patients with sporadic ALS. They included in their study separate categorization for vegetables, fruits, grains, legumes, and nuts and seeds. In this study, PALS with a higher intake of total fiber consumed more fiber from vegetables, fruits, legumes, nuts, and seeds, so excluding that grain category. They found PALS who consume more than 19.8 grams daily of specifically vegetable fiber, compared to PALS who consume less than 13.45 grams of vegetable fiber daily, had a longer survival time, and were also positively associated with ALS FRSR scores in the ALS patients. Though interestingly, there were no correlation in survival time in relation to total fiber intake. This was the first study that we found to show that intake of specifically vegetable fiber could possibly be related to a change in disease rate as well as survival time in PALS. Though it is important to note that this study had a few limitations. First, fiber intake was measured only once at the time point of survey, which might not be reflective of the participants' long-term dietary intake. While this research is interesting because it does relate a direct impact of diet on the progression of the disease, it is important to note that the participants in the highest tertile of total fiber intake also had a higher rate of exercise and sun exposure, which might be more indicative of differences in the ALS FRSR score. And what I mean by that is that these patients just may be less progressed in their disease, so they're able to tolerate higher levels of exercise, and they're likely more mobile to go outside and get that sun exposure, and therefore have a higher ALS FRSR score. Although the score was different among the tertiles of total fiber intake, there were no differences in BMI or bulbar score, which could be reflective of the participants' ability to eat at time point of dietary survey. Again, looping back to that thought that they have a lower disease progression at the point of the survey. The lack of disease progression may suggest that the PALS are able to consume higher amounts of fiber, as they may have less dysphagia symptoms, higher appetite, and just an increased ability to consume those high fiber foods. But based on this research, you et al. Suggested PALS consume at least 20 grams of dietary fiber per day, which is based on the Korean dietary reference intake of 20 to 25 grams of dietary fiber per day. To date, this was the only study which provides a recommended amount of dietary fiber for PALS. However, since correlation does not mean causation, more studies will be needed to determine if decreased fiber intake negatively impacts disease progression or affects survival time, or if disease progression results in increased difficulty to consume adequate fiber. Just briefly, as an interesting aside on fiber and ALS, I would like to highlight that other research has explored dietary fiber intake and ALS risk, or the risk of developing the disease. Fondell et al. Explored the relationship between dietary fiber and ALS risk in a pooled analysis of 5 large prospective cohort studies. The study encompassed a total of 1.05 million men and women, of which contributed 1,133 cases of ALS during a mean follow-up of 15 years. The study found that neither insoluble, soluble, nor total fiber intake was associated with ALS risk. This research is interesting as there is evidence that inflammation is a prominent feature of ALS and is present in both the nervous system and the peripheral immune system. Because of this, fiber intake is thought to be a possible modifier of ALS risk, as it's been shown to lower concentrations of inflammatory markers, including C-reactive protein, tumor necrosis factor A, and plasma interleukin 6, which are thought to be associated with a lower risk of death from inflammatory disease. While the role of inflammation in ALS is a complex topic, and the emerging research and discussion of dietary fiber intake and risk of developing ALS or the progression of symptoms is out of the scope for this discussion, it is worth mentioning these studies as the association between dietary fiber intake and risk of death from inflammatory disease continues to evolve. So how does all this information relate to our patients living with ALS? As we reviewed, the DRIs generally recommends between 25 and 38 grams of dietary fiber per day in the healthy population. However, as Dominique has discussed, there may be evidence of bowel dysmotility and constipation in PALS, which means we have to alter these recommendations in our nutrition practice. A patient with severe bowel dysmotility may not tolerate the recommended amount of fiber without adverse effects or worsening of constipation symptoms. But let's say that for an individual patient, based on our clinical exam, that we do find our recommendation is to increase fiber intake to improve their symptoms. Within the confines of ALS, fiber intake tends to naturally restrict itself throughout the course of disease progression, and there's a vast variety of reasons why this might occur, such as dysphagia or having difficulty chewing or swallowing food that is naturally higher in fiber, such as raw fruits and vegetables. And just anecdotally in my practice, I commonly see some of the first signs of dysphagia or chewing or swallowing difficulty presenting in raw fruits and vegetables, and have had many patients list the mixed or tough texture of salad, for example, as one of the first food types eliminated from the diet. And this could be whether they are experiencing true dysphagia symptoms or simply having fatigue with the act of eating these tougher to chew items. Another obstacle is that sometimes GI upset or constipation may reduce overall intakes because of discomfort and can cause early satiety symptoms. And finally, a generally poor appetite from a variety of factors can decrease portion sizes at meal times that inevitably lowers the intake of fiber. If continuing or increasing fiber is a recommended goal for the individualized patient, this often means modifying textures to make the act of eating fibrous foods more enjoyable or feasible. So what are some of the ways we can alter foods that are high in fiber to personalize it to the patient struggling with fiber consumption? One modifier of fiber consumption can be the act of cooking to a small degree. Some patients assume cooking fibrous foods will decrease the fiber content dramatically. So let's review what the act of cooking can do to fiber content. The general definition of fiber can be thought of as the cell walls of plants. Cell walls are made up of a whole range of different polymers entangled and linked to each other. Some types of fiber we commonly see are shown on this slide, so let's just go through them. Lignin is commonly found in woody tissues of plants and can be found in whole grains and seeds, especially in that bran layer. Although in lesser amounts than in grains, lignins are also present in fruits and vegetables such as asparagus, grapes, kiwi fruit, lemons, oranges, wine, and even coffee and tea. The best example I think of when describing lignin is the grittiness of unripe pears. It is hydrophobic and impervious to most chemicals except extremes of acid or alkali, so it will not be changed much during cooking, and you won't be able to change the fiber content dramatically in these foods. Pectin is a complex polysaccharide made up of a whole range of different sugars. These interact with calcium ions to form gels, so like in jam or jelly, where the calcium is either naturally in the fruit or added during the cooking process. And if you remove the calcium ions, then the gels fall apart. This can be done easily by boiling, where calcium leaches into the water, and some pectin may even end up in the water itself as it becomes partially soluble. This is where that pectin haze comes from that can make a glass of wine or a glass of beer cloudy. Cellulose is a common food additive to prevent caking and is used as a thickener and a stabilizer, and can be found in root and leafy vegetables as well as legumes. It is chemically resistant to cooking and pH changes, so these will not affect this type of fiber. Hemicelluloses are polysaccharides, with agar being a common example. The key difference between a cellulose and a hemicellulose is that cellulose is an organic polysaccharide molecule, where hemicellulose is a matrix of polysaccharides. Once solubilized, most polysaccharides will be susceptible to acid or pH, or base, especially at higher temperatures. Most foods are not sufficiently acid on their own to do this, so most cooking processes won't do this either. If you measure fiber before and after cooking, you'll mostly get the same result. So, outside of the limited chemical alteration of high fiber foods that can also make them easier to consume and digest, there are also some texture modification alternatives that can be explored. Texture modifications, such as cooking and mashing, are preparations that can be used to make fiber easy to swallow and help intestinal transit, which can be especially important in bulbar onset symptoms. Texture modification and cooking of fiber-containing foods is often necessary for diet consistency limitations and can help ensure that its consumption is not excluded from the diet when it is appropriate and needed to maintain bowel regularity. So some common examples of texture modifications is blending raw spinach into a nice green smoothie, uh, cooking and pureeing apples into applesauce, cooking and blending raw vegetables into a nice blended soup, and substituting a morning cold granola for a nice hearty oatmeal. So what does this all mean in our day-to-day practice? With limited research data available, it can be difficult to determine the effects of dietary fiber in ALS and to make generalized recommendations for PALS. Again, the 2005 DRIs for healthy individuals recommends between 25 and 38 grams of dietary fiber per day, and you et al. Suggested PALS consume at least 20 grams of dietary fiber per day based on the Korean DRIs of 20 to 25 grams of dietary fiber per day. However, in light of the concerns for increased rates of constipation, possibly related to bowel dysmotility, and decreased ability to consume sufficient fiber from a variety of disease-related factors, it is likely we may have to alter these recommendations for fiber consumption throughout the course of disease progression. First and foremost, gastrointestinal dysmotility symptoms should be managed in an interdisciplinary manner through diet and medication changes as applicable. Excessive or inappropriate fiber intake or supplementation may lead to bloating, abdominal pain, gas, worsening of constipation, cramping, and dehydration. And it has to be cautioned that with poor colonic transit in PALS, excessive bulking of stools through dietary fiber may have the opposite effect of worsening constipation or increasing obstruction potential, and should be used with caution, especially with those confined to a wheelchair or at the later stages of their illness. The big takeaway in light of these symptoms is that fiber should be slowly introduced into the diet, and intake should be modified strategically based on monitoring of gastrointestinal symptoms. In order to make changes to fiber intake, it remains crucial to obtain a patient's diet history and continually monitor any changes to the diet recall to determine the amount of fiber consumed and to aid patients in making the appropriate modifications based on gastrointestinal symptoms, whether that is increasing or decreasing the fiber in their diet. It is common, but not exclusively true, that patients will need to decrease dietary fiber intake pending symptoms of gastric dysmotility. Clinicians may need to provide nutrition education on fiber-containing foods and how to make adjustments on a modified diet, such as those who are no longer able to consume raw apples may better tolerate applesauce. And finally, another option to consider is oral nutrition supplements if the PALs are unable to consume sufficient oral intakes for bowel regularity.
Okay. So depending on the disease progression and goals of care, some PALs may decide to obtain long-term access and transition from oral intakes to enteral nutrition support. If you're a dietitian, you've heard it 1,000 times. Enteral nutrition is the preferred route of nutrition support for individuals with a functional gastrointestinal tract when oral intakes are no longer sufficient or possible. Specifically to PALS, enteral nutrition often begins as supplementation to oral intakes, but may transition to meeting full nutrition requirements as the disease progresses, with pleasure feedings possibly being continued for quality of life purposes. Indications for a gastrostomy may include weight loss of greater than 5 to 10% of their usual body weight, ongoing dysphagia, prolonged meal times for more than 45 minutes, and changes in pulmonary function. Some literature does suggest that PALs not using enteral nutrition can have been found to consume about 10 to 19% less than the recommended daily calories, which may lead to a reduction in body fat percentage and weight loss. If in line with goals of care, enteral nutrition can be used to stabilize weight and body mass index. The prevalence of constipation for those receiving enteral nutrition support can range from 15 to 29% in the general population. One article suggested that constipation is the most common intestinal motility disorder found in individuals receiving enteral nutrition support. PALs have a higher frequency of reporting gastrointestinal symptoms, including bloating, constipation, diarrhea, and abdominal fullness, compared with other patients with normal gastrointestinal function receiving enteral nutrition, including neurological diseases such as stroke, intracranial hemorrhage, and trauma. To date, there are no current guidelines that provide specific enteral nutrition support recommendations for PALs. Zhang et al. Surveyed 148 healthcare individuals associated with an ALS clinic to determine EN practices of ALS providers. Of note, participants were allowed to free text additional information. They found two major themes included there's no set formula or procedure that works for everyone, and hydration is not recommended adequately. All right. There are now a vast number of enteral formula options available that range from standard polymetric formulas to food-based, commercially made blenderized formulas and everything in between. Enteral nutrition formulas enriched with fiber are designed to normalize intestinal transit and reduce laxative use. Formulas can be classified by structure, fermentation potential, viscosity, and solubility. What I find interesting is that a formula may contain a single source or a blend of fibers in varying proportions, so the amount of fiber and fiber type can vary between different formulas. A small amount of information is available to guide practitioners in choosing home enteral nutrition formulas for long-term care patients. As I just mentioned, there are no current guidelines in recommending specific enteral nutrition formulas for PALs. ESPN does have guidelines for home enteral nutrition support, which state a standard commercial formula is a first-line choice unless there's a specific justification for a blended tube feed. As we know, a standard commercial formula may or may not contain fiber. When it comes to fiber-containing formulas, Aspen does recommend using a fiber-containing formula to manage both diarrhea and constipation due to the proposed functionality of fiber to maintain gastrointestinal motility and regularity. I did want to call out the fact that most clinical trials exploring enteral nutrition and fiber focus on diarrhea. As Brittany had explained earlier in the presentation, the type and amount of fiber can change the physiological effects on the gastrointestinal system. Therefore, we search for enteral nutrition guidelines that discuss both fiber and gastrointestinal dysmotility. To date, there are no enteral nutrition recommendations for home care patients with gastrointestinal dysmotility. The only guidelines available are Aspen 2016, which recommend avoiding both soluble and insoluble fiber if there is a risk for bowel ischemia and severe dysmotility. However, these are specific to the critically ill population, leaving us with a knowledge gap for our home care patients. Data and guidelines surrounding routine use of fiber-containing formulas in PALs are inconclusive. Therefore, enteral nutrition recommendations should be based on clinical judgment. We need to select a formula that considers the overall clinical picture of the individual, as there are no definitive best practices in the PALS population. There are benefits to using a fiber-containing formula. However, bowel regularity and gastrointestinal symptoms must be continuously monitored, given the vast array of enteral nutrition formulas available and the varying amounts of total fiber and fiber composition. Given our discussion on gastrointestinal dysmotility and increase in MCTT as the ALS-FRS-R score decreases, further research is warranted to determine tolerance of different enteral nutrition formulas throughout all stages of ALS. Hydration remains an important component of managing constipation, especially when increasing fiber intake. Water is needed to support lean body mass, and fluid requirements can fluctuate with weight and decrease with age. This chart reviews various formulas used to estimate hydration needs. In the general population, some of us may be familiar with the criticisms that weight-based equations can overestimate fluid requirements for larger individuals and underestimate fluid requirements for smaller individuals, with some equations taking into account both body weight and age. PALS may be at increased risk for dehydration due to dysphagia with liquids, increased caloric demand with respiratory and motor function, increased sialuria, decreased mobility to hydration sources, fear of incontinence, and poor decision capacity due to cognitive impairment. Additional fluids should be considered for individuals with severe diarrhea or emesis, large draining wounds, constant drooling, and persistent fever. Okay, so Scagnelli and al. Explored hydration in PALS and its effect on survival. They looked at water turnover using the doubly labeled water method, with daily water turnover referring to the replacement of body water that is lost in a measured period of time. What they found were PALS have decreased mean daily rate of water turnover compared to healthy controls. Risk factors for reduced water turnover were female patients, bulbar onset disease, and lower values of ALS, FRSR, FVC, and BMI. They also looked at survival and found that survival was progressively shortened with decreased water intake. Even after adjusting for age, bulbar site of onset, FVC, and BMI, water intake still had a significant effect on survival. What I found interesting was that lower water intake had a greater negative impact on survival than BMI. When looking at predictive fluid equations, they found that fluid calculations of 1 milliliter per calorie per day and the Holiday-Seeger formula both underestimate fluid needs in PALS. What they recommended as the best choice was the Kosarsky equation with a correction factor. I added a small segment from the article to the slide. So equation 9 is the Kosarsky equation with a correction factor. What they found was that equation 9 slightly overestimates water intake in ALS compared to DLW measured water turnover. However, since water turnover in ALS patients is low, this equation likely corrects for the shortfall. Therefore, they recommended the use of equation 9 to estimate water requirements in PALS. They concluded that further research should focus on optimal nutrition and hydration in PALS to prospectively determine the effects on function, survival, and quality of life. Right. Dehydration can lead to physical deterioration, constipation, and urinary tract infections. Given PALS are at increased risk for dehydration, it is important to monitor for signs of dehydration, which include dark-colored urine, dry mouth, thirst, changes in weight that can be related to dehydration. Dehydration can lead to thickened mucus or secretions. Furthermore, excessive drooling and sweating can be an indicator for needing to increase fluid intake to make up for fluid losses. Given the relatively limited research available on estimating hydration needs and all the challenges previously discussed, ongoing monitoring and clinical judgment is needed when estimating hydration needs for PALS. It is important to discuss their fluid intake and any challenges they may be having regarding achieving their fluid goals. It is incredibly important to work with your speech language pathologist to determine which consistencies are safest for your patient. If thin liquids cause discomfort, consider drinking naturally thicker liquids such as milkshakes, smoothies, nectars, tomato juices, and pureed soups, in addition to using commercial liquid thickeners. For those pals who are receiving enteral nutrition and are not able to achieve their fluid goals during enteral nutrition infusion, consider spacing out the free water flushes throughout the day to increase fluid intake and meet estimated fluid needs.
Okay, so finally, to end our discussion, we wanted to touch on pharmacological management of constipation. Specific medication recommendations are understandably out of the scope of the registered dietitian, but the pharmacological management of constipation is such a vital aspect of patient care. Maintaining bowel regularity often means the addition of a scheduled and consistent bowel regimen in the form of both over-the-counter and prescription medication. I would like to briefly review some of the generalized recommendations and considerations we frequently encounter within our own practices for the pharmacological management of constipation. Pals surveyed by Samara et al. On bowel, urinary, and pseudomotor symptoms self-reported that the most effective treatments of constipation were laxative use, dietary fiber supplementation such as psyllium and polyethylene glycol, as well as diet and exercise. While on the topic of medications, we also wanted to point out additional consideration should be paid to medications that are commonly prescribed to pals that are not directly related to GI symptom management, but can still affect the overall function of the GI tract. For example, scopolamine, which helps manage sialorrhea and decrease secretions, may exacerbate constipation as it dries secretions in the mouth, but it may also decrease gut motility. Glycopyrrolate inhibits salivary gland and respiratory secretions, but can also dehydrate the GI tract. These medications are something to consider and take into account when reviewing medications that have nutrition implications within the patient history. But let's dive into those bowel regimen medications. Bowel medications can be broken down into their main mechanisms of action, with medications of note being fiber supplementation, stool softeners and docusate, suppositories, and prokinetic agents. Other medications to consider also include senoglykoside, biscadol, lactulose, and magnesium citrate. You can refer to the table on the right for common bowel regimen medications, but let's touch base on the basics. Fiber supplementation, such as psyllium, add bulk to the stool and make it easier and softer to pass. I did want to pay special attention to psyllium-based supplements because they're degraded by colonic bacteria and may lead to abdominal bloating and increased flatus. Stimulants like senna stimulate the mesenteric plexus and cause increased secretions and the intestines to contract. Stool softeners such as docusate sodium and calcium moisten the stool by drawing water from the intestines. Lubricants like mineral oil enable stool to move through the colon more easily and gently. Osmotics such as magnesium citrate increase secretion of fluid from the intestines and draw water into the lumen of the bowel. Enemas and suppositories like a simple tap water enema soften stool and provide lubrication and stimulation. Finally, prokinetic agents like erythromycin can enhance motility by increasing frequency or amplitude of gastrointestinal organ contractions with varied effect on different areas of the GI tract, though they have limited use due to their limited efficacy and high side effect profile, such as diarrhea, abdominal pain, and nausea and vomiting, as well as non-GI specific effects such as regular heartbeat, blurred vision, depression, and anxiety, and tardive dyskinesia, which are involuntary, repetitive body movements. I think a common theme we can see in many of these medications is the importance of hydration for the mechanism of action to be effective. A dehydrated individual will not have the same stores of fluid that can be drawn into the intestines to allow the bowels to move more freely, which is what many of these medications rely on. I also like to point out the differences of bowel regimen medications by preventative versus restorative care, such as implementing daily fiber to promote bowel regularity as opposed to treating constipation symptoms as they appear. For preventative care, using stool softeners is often advisable. Excuse me. There are also numerous prescription-based medications that can be prescribed if the over-the-counter medications are unsuccessful. While we are often asked for specific recommendations for bowel medications and fiber supplementations by patients and caregivers, it is important for PALS to discuss pharmaceutical options with their medical provider.
All right, so we wanted to summarize our implications to practice in a stepwise approach to constipation management. First, lifestyle modifications include both diet and enteral nutrition considerations. Physical activity is a common recommendation for improving constipation. However, we have to keep in mind some PALs have limited mobility. Therefore, physical activity recommendations should be made by our OT and PT colleagues. Secondly, hydration should be considered in both oral and enteral routes as applicable. And lastly, pharmacological management includes over-the-counter medications, prescription medications, and supplements. Please remember to work with your medical team when identifying someone who would benefit from a scheduled bowel regimen.
So, in conclusion, gastrointestinal dysmotility can be a common and burdensome aspect of PALS care management. Bowel regularity is a major aspect of maintaining continued quality of life. In a progressive disease, patients should be continuously monitored, and recommendations may need to be altered or updated to address symptom management. Constipation can impact oral intake and make the selection and tolerance of enteral nutrition formula difficult. And the RDN should continuously obtain a diet recall or reassess the enteral nutrition formula prescription to monitor for changes in the amount of fiber and fluid received as it relates to symptoms of constipation and throughout disease progression. And finally, as we can't say it enough, gastrointestinal symptoms should be managed in an interdisciplinary manner through nutrition-related adjustments, appropriate hydration, and medication changes as applicable. Any questions?
Well, thank you so much, Dominic and Brittany. That was absolutely fantastic. So we're now going to open it up for Q&A.